Hello to everybody. On
Hello.
behalf of the International Federation of Kidney Foundations, World Kidney Alliance, I welcome all of you to our special webinar today on the environment and kidney health. The International Federation of Kidney Foundations, World Kidney Alliance is a worldwide movement which seeks to promote better kidney health with primary, secondary, and tertiary preventive measures. We want to create awareness of kidney disease throughout the world, promote organizations that are helping towards kidney disease, and promote individuals and groups of people who are creating awareness of kidney health and helping people form foundations all over the world. So today's webinar has been curated by our secretary, Dina Abdelatif, who is our Secretary General from Egypt. I welcome her, and I welcome our moderator, who is also an IFKF-WKA member, Dr. Manjusha Yadla from India. And I'm very grateful that we have two wonderful, renowned speakers today. We have from Lebanon, Professor Antoine Barbary, and we have from Belgium, Professor Raymond Van Holder. So along with doing webinars like this, the IFKF-WKA also promotes World Kidney Day, along with International Society of Nephrology. This was the brainchild of Professor Joel Koppel, who also formed IFKF-WKA and has encouraged the World Kidney Day. And we are going into our 20th year of World Kidney Day, so we want you all to be part of it. So thank you, Dina. Over to you for the Environment and Kidney Health webinar today. Thank you.
Thank you. Thank you, Lata. And welcome you all for this very special webinar. And for some times now, we are trying to have a series of webinars that will continue. And we urge all our members to be part of it. And all our webinars are directed for everyone, for the nephrologists, for all the kidney health lines, and all the patients, and everyone who is dealing with the kidney patients in whatever perspective. Today, we were having a very, very special webinar with two distinguished speakers and my co-moderator, Manju Yadla, who will introduce also herself now, and then we will directly proceed for the first speaker. Manju?
Thank you. Thank you so much. At the outset, I thank the IFKF-WKA for inviting me to moderate the session, and it's extremely glad and definitely honored to be part of this great session being organized by IFKF-WKA. I am Professor Manjusha Yadla. I'm Professor HOD Nephrology, Gandhi Medical College, one of the public sector hospitals from India, and I'm also the Deputy Chair of International Society of Nephrology social media team, also member of IFKF. So today we are here to discuss, as Dr. Dina said, about the environment and kidney health, which we all know the kidney is going to be affected because of environmental toxins, starting from the industrial pollutants as well as the herbal medicines. So many are the heavy metals, etc., etc. So here we are to learn from the eminent speakers who have joined us from Lebanon and Belgium. So may I take this opportunity to introduce the first speaker, Dina? You want to do, or? Yes,
Okay.
Dina, over to you. Yeah.
Okay. So it's my pleasure to introduce our first speaker, Professor Antoine Barbary from Lebanon. And Professor Antoine has graduated from the Faculty of Medicine in France, Montpellier for France. He's been affiliated to the Nephrology Research Fellowship in the University of California and had a nephrology clinical fellowship from Los Angeles, from the UCLA. He is the past assistant professor of medicine at the UCLA School of Medicine and ex-Lebanese University Medical Education Program Director at Rizq Hospital. He's a professor of medicine, Lebanese Faculty of Medicine of Medical Science, Middle East Society of Organ Transplantation past secretary, and method of past vice president, past president-elect, past president, and his ethics committee member of the Transplantation Society. So it's my pleasure to introduce Professor Antoine, who will be speaking today about the global warming and the kidney. What's new? Professor Antoine, the floor is yours.
Thank you. Thank you, Dina, for your kind introduction. Today I'll be talking about the environment, in fact, the global warming and the climate change and its impact on the kidney. We'll define what climate change is, what are the causes of global warming, and what are the medical consequences on our biology as humans, as animals. And also we'll emphasize on the potential impact for nephrology, and we'll conclude with some remarks. So what is climate change? Well, climate change, in fact, human activity have profoundly altered the functioning of the planet's ecosystem. And this has led, of course, to the greenhouse gases emission, which has caused global warming, leading to the climate change and triggering the mass extinction of both terrestrial and marine life. And there is a strong link between climate change and biodiversity loss. In fact, it's a vicious circle where climate change through several mechanisms lead to loss of biodiversity, which in return through different mechanisms lead to climate change. So it's a vicious circle. So what are the effects of climate change? In fact, we know we are all heard of, and we're observing this all over the world. It is the rising temperature that we are observing, leading to more worse storms, more and worse forest fires, more heat-related illnesses, more and worse droughts, rising levels, causing land degradation, leading to the biodiversity loss, and of course, significant economical losses all over the world. And if we look at the annual carbon emission by region, in fact, we see that since the 1950s, over the last 70 years, there's been significant increase in the carbon emission, mainly in the three areas, China, USA, and Europe. And this is associated, of course, in parallel with a rise in the planet temperature by 1 to 1.2 degrees. What are the causes of global warming? Well, the causes is the way we are living today. It is our practices today and the way we deal with our planet on a daily basis. It is related to the rapid industrialization, the way we use energy, our practices in agriculture, the deforestation, consumer practices, the way we transport through, and what we use for transportation, the way we extract our resources, and of course, this is leading to significant pollution. And the social impact of climate change, of course, it's displacing people, leading to poverty, loss of livelihood, hunger, malnutrition, increased risk of disease, and global food and water shortages. And this is an example of, for instance, of the gas emission and the per capita use for road transportation. We're still relying mainly on fossil fuels. The way we perform agriculture as well as the meat industry. We can see that in the meat industry, the cattle industry, in fact, is the most contributor to the gas emission. And in the agriculture practices, it is the, sorry. Why I lost my...
We can hear you, sir.
Yeah, but I lost my my slides.
We can see your slide, the global agricultural consumption.
Yeah, I cannot see it. No. I'm not getting the sharing.
So maybe you can try to reshare again.
Okay, now I got it back. And in the agriculture field, it is the rice industry that really is causing a significant emission. Also, most importantly, it is the way we practice medicine. In fact, there is a very strong relationship between gas emission and the sophistication of the healthcare system. We can see that USA, Japan, and Europe are a major contributor, in their healthcare sector for the greenhouse gas emission. And this, of course, is leading because of the increase in temperature. This is leading to the increased number of people exposed to heat wave. And accordingly, there is leading global heat-related mortality for population older than 65 in many areas of the world. So what are the medical consequences of global warming and the oxidative stress? Well, as you know, we live in a healthy state, in a perfect harmony. We have a healthy state balance where we have the oxidative system is balanced by an antioxidative system. And oxidative stress, in fact, is related to the increased production of oxidative free radicals and reactive species, which are toxic, and or decrease in the antioxidant defense protein. The oxidative stress is causing, of course, the biology and the cell biology to be affected, where the component of the cell, such as protein, lipid, and nucleic acid, are affected by oxidative stress. This is lead to a cellular dysfunction, leading, of course, to impairment in the energy metabolism, impairment in cell signaling, altered cellular transport, immune activation, inflammation, and vascular thrombosis. Or it can lead also to the apoptosis of the cell and the death of the cell. What are the sources of the oxidative stress? Well, water pollution, air pollution, the way we eat. Red meat is a significant, has the same impact on the oxidative stress. Sweetened beverages, smoking, the drugs we take. These represent chemical toxins that can lead to biological oxidative stress. But also there is infection, the psychosocial stress we're living today globally, and the invisible electromagnetic radiation, which also, as we will see, contributes significantly to the oxidative stress. This is the old slide I made looking at the environmental pollution and its link to oxidative stress. This represents, over the last 20 years, more than 1,300 citations addressing this issue. If we look at the global mortality today, there is an estimated 40 to 41 million people who die from non-communicable diseases worldwide, and 80% of these people, they die, in fact, from cancers, cardiovascular disease, metabolic syndrome, respiratory disease, kidney disease, metabolic syndrome, and diabetes, as well as cancer and old age. And the contribution of all environmental pollution to this for the mortality to from non-communicable diseases is responsible for 20 to 50% of the deaths. Worldwide, there is 2.1 billion people are overweight or obese, and overweight and obesity today are the fifth leading cause of death in the world, accounting for nearly 3.4 million deaths annually. This is what we see today in the US. This is also in the US. In children, obesity today is pandemic. These two kids, they are adolescent, they died. Their deaths were attributed to COVID-19 within 1 week. They are a brother and a sister. But in fact, as you can see, this was reported by the CNN. Now, to talk about air pollution, we need to talk about particulate matter. And particulate matter are nanoparticles or micron particles with different size, defined as 2.5 micron and the PM10 as 10 micron. It's very important because the size of the particulate matter has an very important impact on our biology. The smaller the size, the deeper the particulate matter enter our system all the way to the bloodstream. And we can see this is on the right-hand side. The origin of the particulate matter, whether 2.5 or the 10, they come from mainly combustion, from different particles, from metals, from dust, from pollen. And most importantly, if we look at the coronavirus, which is a nanoparticle, the size is 0. Micrometer, which represent 100 nanometer. There is a recent report in the Lancet have linked the climate change and the COVID-19. which they define as a converging crisis. And the conclusion of the report was that the climate emergency and COVID-19 are both born of human activity that had led to environmental degradation. And this is a report from the CDC looking at the risk factors that were responsible for the severe illness in COVID-19, in hospitalized COVID-19 patients. Well, they found that hypertension, disorders of lipid metabolism, obesity, diabetes with complication, and most importantly, anxiety disorders were the strongest factor for severe COVID-19 illnesses. Another important risk factor for oxidative stress, it is the electromagnetic pollution that I call the invisible smoke we're living in today. This is invisible because we don't see it, but we are surrounded by it and surrounded by antennas, by the phone. And today also we're moving to a new generation of the mobile telephony, which is a 5G, in order to meet the need for Internet of Things and smart cities. This slide represents, over the last 30 years, the relationship between oxidative stress and electromagnetic radiation. You can see it's a significant number. So there are thousands of papers showing adverse effect from wireless radiation, even below current safety guidelines, applied in either isolation or part of a combination with other toxic stimuli. This is the sources of the electromagnetic radiation. This is represent every aspect in our life, from mobile telephony, mobile phone, microwave, Bluetooth devices, baby monitor, radars, smart meter, and wireless local area network. And the most important polluting environment is our car, because it's loaded with, as you know, sensors and Bluetooth. So the environmental pollution, in fact, we can divide it into the physical chemical, the visible chemical, and the invisible EMF. And as you can see here, I like the slide on the left because it shows us that whatever we do to Mother Nature, we end up swallowing all what we use. So we hurt Mother Nature, but in the same process, we hurt ourselves. What is the relationship between COVID-19 mortality and non-communicable disease and environmental pollution? In fact, 0.3% of all those who died from the COVID-19, 85%, in fact, they had non-communicable disease. They had one year life expectancy. And most importantly, they have the age of 85 and above. Also, it was very important, and this is a recent review we published in ECT, that there was a strong linear relationship between the air pollution and the number of COVID-19 cases, the number of COVID-19 severe cases, and the number of deaths from COVID-19. This is a very important paper looking at the association between long-term exposure to ambient air pollution and COVID-19 severe. So it shows that chronic exposure to air pollution may contribute to severe outcomes after SARS-CoV-2 infection. On the left-hand side, we see the total mortality from COVID-19 over the whole pandemic, in the different regions of the world. And we can see, where the most important mortality was in North America, in the Americas, in Europe, and in Asia. These are the areas and the region that they are the most polluted, as you see on the the right-hand side. So what is the mechanism? We propose a mechanism for disease severity in COVID-19 patient with non-communicable disease. So the patient is exposed to different stressors, as we mentioned. So this is caused to oxidative stress, leading to inflammation, altered immunity, impaired tissue blood supply, causing the non-communicable disease. And if these patients with non-communicable disease are exposed to electromagnetic radiation, as well to any other infection or to the COVID-19, this leads to increase in inflammation, altered immunity, worsening tissue oxygenation, and of course, with fear and panic, it increases the risk of death. And that's what happened during the COVID. So what is the Wuhan connection? The Wuhan connection had all the stressors that I mentioned. They have the air pollution from industry, from cars. And during 6 months, these are photos from Wuhan. 6 months, during 6 months, people in Wuhan, they have to wear the mask because of the pollution that they have. They eat the toxic food, and most important, they were, as we will see, exposed to the 5G. We're the first city in the world where 5G was rolled out, 1 month before the declaration of the pandemics. And this is a photo from the, from the NASA, looking at the nitrous oxide density 1 year the first on the top one, 1 year before the COVID pandemic, and the one in blue, it is 1 month after the declaration of the lockdown in China, where you can see the complete difference, the importance of the pollution over Wuhan. And there are several reports that linking the polluted air that could be an important cause of Wuhan pneumonia. The 5G network, in fact, was rolled out 1 month before the declaration of the pandemic. It was on November 1st, 2019. And there are several reports showing that could be a link between the coronavirus and the 5G, considering that Wuhan could be one of the most polluted 5G electro-polluted cities on the planet. And we heard a lot about the camel, the bat, the pangolin, and the humans. All these, what they have in common, they're all mammals. And if a mammal cell is exposed to any or one or more of these stressors that we mentioned, this is lead to oxidative stress. It can lead either to apoptosis or damage in the cell with the resulting waste and product that could be wrapped with a part of the membrane of the cell through a multivesicular body, leading to the excretion of these through exosomes, in the biological fluid. So could coronavirus and exosome are they similar? Well, there are several reports, again, showing a similarity, physical and chemical characteristic similarity between the exosome and the retroviruses. With retro, as you know, it's a virus like the COVID-19 virus. This is a COVID-19 on the left, the exosome on the right. You can see there is a chemical similarity in terms of the structure of the cell, as well as the content of the exosome. Could be mRNA, could be DNA, could be microRNA or proteins or lipid. This is the structure similarity. You can see the size is exactly the same between the exosome and the COVID. And this is a review we published recently on the COVID-19 pandemic, covering 3 parts from the early on, the outbreak, all the way to the vaccine mandate. We called it a different perspective, and it involved more than 500 scientific references. So in the part 1, we propose a new model for the outbreak, for the pandemic, what happened. We look at the Wuhan scenario, where we have environmental pollution in terms of air, pollen, and water. This is lead to a particulate matter formation as well as bioaerosol when they combine with the pollen, in addition to other stressors such as the diet and the psychosocial stress. And the beginning of the 5G 1 month before the pandemic, this had led significant exposure of humans and animals, leading them to the formation, to the oxidative stress and the production of massive amount of exosomes and the shedding of these exosomes with a bidirectional exchange among a human and among animals, and between a human and animals, of these exosomes and nanoparticles. Why? Because these mammals, they were exposed to the 5G. They were microwave, like, for instance, in the market, where the animals as well as the humans, they come into proximity, where usually they are not into proximity. So this is with the shedding and the exchange of this exosomes, it lead to a bidirectional exosomal exchange between animals and humans. And the SARS-CoV-2, in fact, it has an exosomal biogenesis, leading to the outbreak, that started in Wuhan and then was spread all over the world through traveling. In fact, the SARS-CoV-2, it's a chimera virus. And it's a chimera virus that contains different antigenic material of animal as well as a human origin. And this will explain the similarity between what was found in the bat and what found in human was 97% similarity. And the exchange that takes place, in fact, is like when we have pollen during spring, we receive pollen and we develop an allergy. In fact, here we have the human as well as the mammals, the animal mammals are producing these exosomes and they're exchanging them. So we call this mammallosis. Instead of zoonosis, where it is a one way from the animal to the human, this is a bidirectional way between animal and human. And this is a very interesting paper in Nature in 2016, looking at the showing the importance of the exosome RNA, where they took a mouse exosome RNA from a mouse mast cell, and it was transferred to another mouse mast cell, which started to produce mouse protein. The same exosome of mouse origin was transferred to a human mast cell, which started to produce proteins of mouse origin. So the exosome, in fact, show it's a mediate a transfer of mRNA and microRNA as a novel mechanism of genetic exchange between cells. And in fact, if we want to look at it, in fact, the exosome has two applications here, the mRNA vaccine, which is exactly that's the exosome technology, as well as the COVID-19. So what is the potential impact of global warming on the kidney? Well, the climate change mechanism and the effect on the incidence and distribution of kidney disease could be divided into the heat wave, rising temperature, increasing infection, and of course, increase in environmental pollution, leading to either acute kidney injury, kidney failure, formation of kidney stone, repeated acute kidney injury, leading ultimately to chronic kidney disease and dialysis. So what's the relationship from climate change between heat waves and renal injury? In fact, there are two types of heat waves. There is the classical heat stroke. We see it usually in elderly people and sedentary, and the exertional heat stroke, which we see it usually in young people in the outside world, athlete, and heavy work. The clinical manifestation basically is the same. The classic heat stroke can lead to 25% acute kidney injury, while the exertional heat stroke, it's much more important. The acute kidney injury, it's 75%, is associated with rhabdomyolysis and several severe electrolyte disturbances, leading ultimately, if it's repeated, to what we call chronic kidney disease of unknown origin. The pathogenesis, the proposed pathogenesis for recurrent heat stress, in fact, it is excessive sweating, leading to chronic dehydration and hyperthermia. The chronic dehydration lead to hypovolemia, stimulation or activation of renin-angiotensin system, causing vasoconstriction and decrease in renal blood flow and ischemia, and ultimately causing kidney injury. The hypernatremia associated with increase in osmolality leads to increase in ADH and stimulate the polyol pathway, leading to increase in uric acid formation, aciduria, oxidative stress, crystalluria. Also, the oxidative stress decrease in nitrous oxide, decrease in renal blood flow, and ischemia. Regarding the hyperthermia, it can cause rhabdomyolysis, causing increase in uric acid, or directly a kidney injury. It can lead to inflammation, leading to direct kidney injury. Also could be activation to the renin-angiotensin system, as well as the sympathogenic system, causing inflammation and kidney injury. And in a recent report in New England Journal of Medicine, they proposed the following mechanism. In fact, what they call the Mesoamerican nephropathy. It is a combination of heat exposure on which is superimposed the effect of toxins and toxicants, as well as infectious disease, leading to kidney inflammation, ischemia, and tubular injury, causing the so-called Mesoamerican nephropathy, or the chronic kidney disease of unknown origin. This is a pathology in the acute phase of the Mesoamerican nephropathy. This data is from Nicaragua. You can see necrotic debris, severe tubular-interstitial mononuclear infiltration, severe tubular-interstitial nephritis with neutrophil infiltration, acute changes with severe tubular-interstitial nephritis. And if we look at the risk for those people who have repeated injury, chronic injury with time, this is over 14 years, we can see certainly there is an increased risk of developing the increased incidence of chronic kidney disease and leading to ultimately to dialysis. Well, this is a chronic renal morphology in the Mesoamerican nephropathy, again from Nicaragua. You can see glomerular hypertrophy, glomerulosclerosis, periglomerular fibrosis, tubular atrophy, as well as interstitial fibrosis. In fact, the first one to be describing the heat stroke related kidney injury was in South Africa in 1967, which you can see the interstitial fibrosis, the cellular infiltration, and the tubular atrophy. This data is from Sri Lanka. Again, they describe exactly the same: glomerulosclerosis, periglomerular fibrosis, glomerular hypertrophy, tubular atrophy, interstitial fibrosis. And in the active form, it can give active interstitial inflammation with lymphocyte infiltration, few plasma cells, and rare eosinophil with negative IF. And the clinical characteristic of CKDU, in fact, it is a decline in renal function of occupational origin related to heat and workload, occurring in hot environment, in sugarcane workers, in high-risk lowland, in high-intensity agriculture workers, in non-agriculture occupation with heavy manual labor, with overall male predominance. What is the relationship between climate change related to infection and kidney injury? Well, I won't go into the detail of every infectious agent, but there are several infectious agents that are associated with climate change and kidney injuries, such as the dengue fever, the malaria, the hemorrhagic fever with renal syndrome, leptospirosis, scrub typhus, Lyme disease, leishmaniasis, and schistosomiasis. What is the mechanism for it? Climate change leads to temperature alteration and increase in precipitation, water shortage, extreme weather events, and altered human contact, human and vectors. And this lead to, in fact, increase in pathogen replication and transmission and survival, increase in waterborne disease causing diarrheal illnesses such as cholera, salmonella, and giardia, causing acute kidney injury. And also when there are floods, there is increase in the vector-related diseases causing malaria, leptospirosis, heptavirus, and other viruses. We cannot talk about infectious disease if we don't talk about the COVID, as I have shown you, since it is the results of our environmental change. This is a study involving nearly 4,000 patients. They look at the relationship between COVID and acute kidney injury. 50% of those who were hospitalized developed acute kidney injury. 20% required dialysis, and 32% they were admitted to ICU. And among ICU patients required dialysis, and half of them died in the hospital. They were older patients, they were male, they had multiple comorbidities, they had increase in serum creatinine at baseline, lower albumin, and lower lymphocyte count. And of course, as in the normal population, any presence of acute kidney injury is associated with poorer survival. No, so not only COVID-19 infection, but also the vaccine against COVID, the mRNA vaccines are associated with kidney injury, as this study have shown, where in the vaccination, you have mainly a vasculitis type, such as glomerulonephritis, diffuse effacement, and acute tubular injury, while with the COVID infection, you have mainly thrombotic microangiopathy, thinning of the basal, disappearing of the basal membrane, and tubular and acute tubular injury. And the mechanism for this acute kidney injury, whether from the COVID or from the vaccine, in fact, it is an ischemic disease through indirect mechanism causing blood clot, or through direct mechanism stimulating, activating the renin-angiotensin system, leading to renal vasoconstriction and renal ischemia, and leading, of course, to chronic kidney disease. What is the relationship between air pollution and cardiorenal injury? This study looked at relationship with diabetes. In fact, most of the pollutant, even in short-term exposure, are associated, trigger the death from diabetes, and type 2 diabetes have stronger association with the air pollution than type 1, and diabetic ketoacidosis and nephropathy were key complications to the linked exposure. The same thing, this is a study looking nearly at 18,000 participants with type 2 diabetes without any macro or micro complication at the beginning. This is from the UK Biobank. They followed this patient for a long period of time, and long-term individual and joint exposure to particulate matter, even at low level below what the WHO limit value, was associated with increased risk of diabetic microvascular complication, diabetic nephropathy, and neuropathy. And of course, the PM 2.5 was potentially being the main contributor. There is long-term exposure to PM2.5 is associated, as this study from China involving nearly 71,000 native biopsies. It's associated with increased risk for membranous nephropathy. This is another study from China showing the link between PM2.5 and increase in IgA nephropathy, risk for IgA nephropathy and end-stage kidney disease. This is another study showing the significant association between exposure to PM2.5 and the increased risk of incident CKD, decline in estimated GFR, and risk for end-stage kidney disease. These are several studies showing exactly the same thing, link between 2.5 and the kidney injury, and not only the long exposure, but also short-term exposure to PM2.5 seems to be associated with increase in all-cause mortality, CVD-specific mortality, and increase in the incidence of cardiovascular disease among hemodialysis patients. And of course, the mortalities when you stratified by age at dialysis initiation, there is increase in the hazard ratio with age as well as was most prominent in elderly people. We published a paper in 2003 looking at the consanguinity and the diagnosis of CKD of unknown origin in the Lebanese hemodialysis population. So in our area in Lebanon also, consanguinity is commonly associated with unknown kidney disease. Usually we see the patient very young, they present before the age of 30, and they are terminal renal failure without having any clue what caused the end-stage kidney disease. What about the climate change and the access to dialysis? You know that dialysis patient or kidney disease patient are particularly vulnerable to the impact of natural disaster and extreme weather event. The study looked at the association, the risk of overall cumulative association between the intensity of the rainfall and the snowfall in relation to the missing of the schedule of hemodialysis. And as you can see, there is a linear relationship. And as we know from the DOP study, missing dialysis, of course, is associated with hospitalization, increase in cardiovascular event, and in mortality. You know, we all our kidney disease, they get sick, so they get hospitalized, they are treated with dialysis, PD, or hemodialysis, or they receive transplant. All therapeutic modality are associated with increase in the greenhouse emission, which lead to climate change, which eventually affect the access to dialysis or the access to transplantation. And if we compare among the dialysis modality, the therapeutic modality, which is the least contribute to the climate change, in fact, transplant reduce overall environmental effect by 96% compared to hemodialysis and 91% compared with PD. So I would like to conclude that we humans, we are supposed to live in perfect harmony in relation to body, mind, soul harmony. And this is it's not enough. We need also to live in harmony, perfect harmony with Mother Nature, because we are part of Mother Nature and we are an extension of Mother Nature. We need nature. Nature don't need us. In order to live in harmony with Mother Nature, we need to be in harmony with its law, with her laws, which is cooperation, adaptation, sharing, satisfaction, harmony. You know, all these what you see, which today we're doing completely the opposite of what we're supposed to be living in. And these are the component of love. So it is time for humans to become conscious of our unconsciousness and loving in complete harmony with Mother Nature and her laws. And the big question should be not whether we want innovation, technology, and research to improve our quality of life, but rather what kind of innovation and technology is there. We just need an artificially intelligent innovation and technology that are protective, cost-effective, eco-friendly, and in perfect harmony with Mother Nature and her laws. Thank you.
Thank you so much, Professor Antoine, for this very enlightening and inspirational lecture. And we are surrounded by many causes or many stresses that could affect the kidneys and could affect the access of the patients to their replacement therapies. And we should be all aware of all this, and we should take all the precautions. We're keeping all the comments and all the questions for till the end of this session, till we listen to Professor Raymond Valholder, and then we get all the questions and get all the answers in the end. So, Mandro?
Yeah, thank you, Dina. Thank you. We move on to the another eminent speaker today joining us from Belgium, Dr. Raymond Van Holder. He is Professor Emeritus at Ghent University, President of the European Kidney Health Alliance and Chair of the European Chronic Disease Alliance. Dr. Van Holder has authored 900 plus publications, including reviews and book chapters, everything on dialysis, uremic toxicity, and various topics concerned with nephrology. He serves as a member of the editorial review board of several journals, and until 2010, he has been the chairman of European Uremic Toxin Work Group, which in fact gives us a lot of idea about uremic toxins. He's member of executive board and treasurer of KDIGO, and until 2011, he served as chairman of European Renal Best Practices, and until 2014, he chaired Renal Disaster Relief Task Force as well. And then he's founding president of the Belgian Society of Nephrology and past president of European Society of Artificial Organs and European Renal Association. We are keen to hear and learn from you, Dr. Van Holder. The platform is all yours. Over to you.
Okay, thank you very much. Thank you very much for the kind introduction and also for the invitation. The topic I have to discuss with you is green nephrology, and more exactly, green kidney replacement therapy. And this presentation also is in the context of my activities with European Kidney Health Alliance, which is a Brussels-based NGO that defends the case of kidney patients and of nephrology at the level of the European Union, and from there, top to bottom, also nationally. And for the time being, ECA is representing 56 organizations in 25 European countries. On the map you see in blue, which countries are EU member states, but we also have non-EU member states like Turkey and United Kingdom, the Russian Federation. And it's maybe interesting to mention that IFKF was once upon a time also a full member of EKHA, and actually they started it together with ISN, but later on they moved out, but we would of course be happy to welcome them again if they want to. Now, the topic is the environment and nephrology. I show you only one slide as an illustration of the ecological disaster that we're living currently, which is illustrating the rise of land surface temperature with the red line over, let's say, roughly the last 150 years. So this is something that did not occur over the last 40, 50 years or 20 years. This started with Industrial Revolution and then increased exponentially. And if we don't do anything, then the rise will become more severe. And what is even more concerning is the blue line. It's the equivalent rise in ocean surface area, which means that we are losing our buffer against land surface temperature increases. And the ocean, that's an open space, so this is even worse. In closed seas like the Mediterranean, where indeed the effects of climate change can be seen, which are more severely than in more northern countries. And there is also pollution, as the previous speaker explained so elegantly. There is plastic waste and a lot of other problems. Now, nephrology.
Sorry to interrupt you, Dr. Raymond. I think you need to change the slides and probably put it in slideshow mode. We are only seeing the first slide, EKHA. The slides are moving.
You only see the first slide?
Yeah, we are seeing the first slide. Can you move the slides? And probably
I am moving the slides, you know.
No, can you make it as a show, please?
It's not moving. Slides are not moving.
Yeah, but I am moving. I can get out again, but I don't. Wait a second. And I know this problem occurs from time to time, but I don't know the solution. I have had it with other speakers as well. I will share again. So window, full screen. First try full screen, window. Share. So that's, now you should see my...
Yeah, can you put it in slideshow mode? Slideshow.
You don't see moving?
We see moving, but it's not in slideshow mode.
I think this is okay, if he's not able to do it full screen.
Right.
It's
okay.
Okay.
We'll go ahead. Yes.
Okay, then I start all over. So nephrology doesn't escape this environmental impact, but also has an environmental impact. So there is a bidirectional relationship. The environment has an effect on, I will move to full screen. I hope that it works. Otherwise I get out again. So the environment has an impact on kidney health and disease, as we have seen, but also kidney health and disease has an impact on the environment, and that will be the topic of my presentation. You see my slides moving?
We are in the 5th slide. I mean, if you can go to the 6th slide.
Do you see any change in slides?
No.
Okay, then I go out of my full screen and then you will be able to follow. So okay, there we are. So most of the things I'm going to present have also been described in this review paper in Nephrology, Dialysis and Transplantation, which we published a few years ago, and where we have several co-authors, which are not only nephrologists, but also patients. There are renal nurses, there are engineers, there are polymer chemists, and this paper was also written within the context of the European Green Deal. You know that the European Commission in its previous legislation started a huge initiative to make Europe more environment friendly. That was called the Green Deal. And I wanted to make the nephrological community aware of the fact that this Green Deal was there and that there was a lot of opportunities, also financially, for investment and research, which were not really well known to the nephrological community, where in general the interest at that time for environmental issues was not that huge. Of course, in the meantime, we had European elections, and we are not entirely sure whether the new Commission will be as adamant in changing the environmental issues in Europe. But anyway, this paper, which came a little bit too late, we were halfway, the previous legislation is describing a lot of the environmental problems with kidney replacement therapy. One of the problems is certainly that it is hard to find comparative studies that are comparing the 3 major different types of kidney replacement therapy: hemodialysis, here illustrated in blue, peritoneal in red, and transplantation in orange. This is one of the few. It has only been published as an abstract. And in this way, it's difficult to check the correctness. That there must be a lot of assumptions. I don't think we can rely entirely on the exactness of the data, but certainly it is clear, as already mentioned by the previous speaker also, that the environmental impact of transplantation, here in orange on the right side, is much lower than for peritoneal or for hemodialysis, which is not unexpected. In general, it is the same as for chronic kidney disease, not on kidney replacement therapy. But you must be aware that healthcare in general is a very environment unfriendly economic sector, one of the most environment unfriendly, and that all patients who rely on quite intensive therapy, often need intensive care, hospitalization, etc., are a source of environmental pollution. But let's say transplantation is a bit like many other chronic diseases, but peritoneal and hemodialysis are much more environmental unfriendly because they are highly technical. But more surprising is maybe the fact that there is not that much of a difference between peritoneal dialysis and hemodialysis. I will come back later to this in this presentation. The point that I want to make over here is that our current expectation would be that peritoneal dialysis is much more environment friendly than hemodialysis because, first of all, for the treatment, we need much less water. And on the other hand, there is also not the transport of the patient to the unit, etc. But in fact, that difference is not so important. And that's what I come back to in later slides. But let's now first concentrate on hemodialysis because we know much more information about hemodialysis. Apart from the manufacturing, which remains relatively obscure, here are the facts, that there is a huge amount of water consumption in dialysis. We have, of course, the 150 or more liters that are used for the dialysis properly, which ends in the sewage system as spent dialysate. But there is much more. There's in total about 400 and 500 liters, and that's related to the fact that we have reverse osmosis reject that also is in most dialysis unit finishing in the sewage system. There is a lot of energy needed. We need to pump the blood, to pump the dialysate, to heat the dialysate, to make the reverse osmosis working. And energy consumption means CO2 production, so greenhouse gas production. And there is also a huge amount of plastic waste because everything in dialysis is single use. And all this may seem and is very abstract, but I tried to express it a little bit more plastically. So for hemodialysis, for all hemodialysis sessions in Europe over 1 year, the CO2 emission is the equivalent of 2.5 million car trips from Brussels to Istanbul, back and forth, of course, with fuel, fossil gas consuming cars. For water consumption, it is the equivalent of 10,000 Olympic swimming pools. And for plastic waste, the weight is the equivalent of 180 million kilograms, and that is the overall body weight of a medium-sized metropolis like Brussels. The population, all people of that city area, the large Brussels area multiplied by 2.5, or if you want it differently, 27,000 times the weight of an elephant, an African elephant, by the way, or 18,000 equivalents of what you could use to fill this huge truck. So dialysis is a very environment unfriendly business. What could we do about it? Well, you may be surprised that I start my explanation with something that has nothing to do with kidney replacement therapy, which is prevention. But the best way to forestall the negative impact of a disease is make that the disease doesn't occur, or that the disease doesn't progress to the stages where the most polluting activities are taking place, and that is prevention. Primary prevention, secondary prevention, to a certain extent, also tertiary prevention. However, if we are looking on what European governments are investing in of their health expenditure in prevention, then it's only 3%, 5% at the maximum. And in fact, it is not different in other areas of the world. And that's not enough. Of course, we cannot do without cure. But if we focus that much on cure and invest that much in cure, actually, this is something that we cannot repair. It is just simply keeping a kind of status quo. If we want to change the course of kidney disease, we have to do it much earlier. And we should not forget that prevention also has an environmental impact. Using more vegetables, having more green is less polluting and less CO2 production. No red meat is not only healthy, like the previous speaker stressed, but also cattle is a huge producer of CO2 and of other greenhouse gases. Doing exercise is using less or producing less greenhouse gases, and also less processed food is not only healthy food, but also there is less plastic waste. So this is one point. The other point is transplantation. But again, also in transplantation, if we look at the European data, there are huge differences. The length of the bar is the number of transplantations per year between the most active and the most passive countries in Europe, Spain and the Netherlands coming up on top. And although there are, of course, local circumstances that influence this, there is a lot of policy issues related. The local communities that are not always prone to propagate transplantation, and also the political area that is not enough doing to advance transplantation. But the rest of this talk will concentrate on the main problems, which are dialysis, peritoneal dialysis, hemodialysis, and I promised you to give a kind of comparison and reflections on the potential differences or non-differences between hemo and peritoneal dialysis. And in the NDT paper, we had also a semi-quantitative table that compared the two strategies. And here in red, we are illustrating a number of aspects where peritoneal dialysis could be worse than hemodialysis, or at least equal to hemodialysis. That's what is illustrated in red. It's always a comparison between PD and hemodialysis, as you can see, and we are taking into account many factors. So you can see that in the area of manufacturing, in fact, water consumption, CO2 production, waste production, all are more important or for PD than for hemodialysis. That's just related to the fact that there is more plastic involved in PD, with this, let's say, 8 treatments or a lot of plastic bags going around, versus dialysis, 1 single filter and 1 single tubing. The same with auxiliaries, where these different exchanges quite often consume more plastic for PD and hemodialysis. And in fact, also for transport, where there is a bonus for PD, definitely, because the patient and also the personnel of the dialysis unit does not travel that much. But the negative impact is that the bulk is larger, transporting, let's say, 16 liters of PD fluid for 2 days. It's much more bulk than 1 dialyzer and 1 tubing set. So here again, peritoneal dialysis is not that much on an advantage. But again, we cannot find any comparisons, real direct comparisons. Therefore, this paper, recent paper from Australia, was very interesting, because here they studied only for PD. So there is no comparison with hemodialysis. The greenhouse, the CO2 emission for the consumables in blue and for the transport in orange. The interesting thing is that this study also takes into account manufacturing, and this for different areas in Australia. So there are a number of striking things. First of all, APD is worse than CAPD. That is not a surprise, because it is consuming also energy. Then second, there are very big difference amongst areas, and that is depending on how much the distance is from the manufacturing plant to be dialyzed patient. And then also the total that you see here in the worst case scenario is something like 4 tons of CO2, and that is more or less comparable to what is reported for hemodialysis. The only difference is that in this study, they took into account manufacturing, whereas in hemodialysis, this was not the case. And again, in some areas, the results are much better than the 4 ton that is worst in these 2 areas here, with the highest peaks from Australia. So in general, we can accept that that PD is more environment friendly than hemodialysis, but not so extremely more environment friendly as we would have expected if we just think of what is happening during the treatment. Now, what are the solutions? Well, the NDT paper is full of solutions, so I advise those who are interested to delve into the paper. There are several tables. I pick out only a few of the most interesting ones, which are here underlined. Dialysate flow restriction. If you go down in flow, there will not be much influence on dialysis adequacy, but you need less heat, you need less warming of dialysate, you need less water. So there is a huge or an important benefit environmentally. solar and wind energy. I don't know how it is elsewhere, but in Belgium, hospitals have a lot of area on the roof for solar panel placement, but they do not do it, or rarely are doing it, or not as well as they could do. Heat exchangers have become a little bit more popular. It's that the warm outgoing dialysate is warming the incoming dialysate. Waste triage, so that only goes to the incinerator what should go to the incinerator, and more durable dialysis machines and electronics. Indeed, most of the machines are made to break down one or the other day, and manufacturers could produce machines that are much more longer be able to work. And more out of the box, repurposing RO reject, for instance, for household use, bathing, toilet flush, laundry, all that water could be perfectly used also in gardening. And in fact, it still also is conform with the conditions for drinking water, and for the waste handling, biodegradable disinfection products, and finally repurposing of plastic waste. In United States, plastic is put into the paint for indicating the side of the roads, and in Australia it is used to make concrete more strong. There are also a number of changes that are ahead. For instance, one is the more compact dialysis systems, which would end up with portable or wearable dialysis. For instance, this type of machine that is currently under clinical evaluation, where due to regeneration of dialysate with sorbents, one needs only 8 liters of dialysis water, which also means that you need less energy for heating, because the water is recirculated all the time, and also heated in part by the body fluids of the patient. And of course, also a need to move dialysis more into the direction of circular economy. In the NDT paper, there is a figure that illustrates a number of options. Of course, I cannot discuss them all with you, but I will come to 2 of them. One is the recycling of polymers, so that they are deconstructed and then reconstructed in polymers, which of course avoids incineration, which means CO2 production. You should realize that all this plastic in fact is carbon, and that once you are burning it, of course, you are producing CO2 that enters into the air. And above, on the right angle, you see the good old reuse. If this could be done in a safe way, then it is also a very elegant solution. Solar energy, wind energy, we discussed already. We also would like to stress the importance of registration. It means that 1 or 2 or 3, 4 people, nurses, doctors with interest in environmental issues are noting the amount of energy consumption, the amount of plastic production, the amount of water consumption for a given unit every month, and follow up and try to find solutions to reduce all this, and that you have an everyday, or not every day, every month evolution of what is happening. And together with this goes also benchmarking. It is comparison of units, all units. It could be, for instance, organized by national societies, but also it could be done on a more local level with a cluster of a few units that are collaborating, comparing with each other, and also inspiring each other in bringing down the environmental impact of a unit. Now, we have talked a lot about solutions, but at the end, I also would want to indicate that already something, and quite a lot of things are happening. This is the guidelines, the recommendations of the EDTNA, the European Nurses Association, on environment-friendly dialysis. It's mostly written for nurses, but also very interesting for doctors. It's all very practical, everyday things, but there is a lot that can be done to make a unit more environment-friendly. And also, for instance, in the UK, the NHS wants to get to zero emission for its hospitals by 2040. In France, the French Society of Nephrology has a green nephrology group and produced green nephrology guidelines that, by the way, are translated into English. And also the Italian Society of Nephrology published recommendations. In Utrecht, they are transforming the unit into a green dialysis unit. And in Germany, the Kuratorium für Heimdialyse, which is a very large provider in Germany, has taken a number of measures to become more environment friendly. And the German Society of Nephrology has developed an online assessment tool to evaluate the environmental burden of units. And finally, there is Green K. Green K is an initiative of concerned nephrologists who want to convince society that more must be done in nephrology to become more environment friendly, and to develop a number of guidelines and also instructions on how to move forward. Also for industry, because also at the manufacturing level, a lot could be done. And this Green K initiative is hosted by the International Society of Nephrology. All those who are interested, who want to become a member, can go to the ISN website and look under the label initiatives. And that brings us to the conclusion of this presentation. The environmental burden of chronic kidney disease is substantial. That's a no-brainer. Prevention, transplantation, and innovative dialysis should tackle this problem. In-depth research comparing several strategies is needed, and environmental burden should be reported for every existing and novel therapy. And nephrologists and nurses should compare the different options and ask for the most environment-friendly one. That finishes this presentation. I'm now ready to take questions, and I thank you for your attention.
Thank you. Thank you so much, Dr. Van Holder. It is indeed an amazing and brilliant presentation that's been done. Of course, it's a upfront task for everybody, in fact, much more so with the LMICs, as to how to deal with the humongous burden of the dialysis generation. So the focus has to be, and the initiatives have to come from the global countries with respect to the green initiatives, just not in certain countries. It has to be a global initiative. I'm sure it's going to be a long way, but then small steps are the beginning of the huge steps that it's been started. And the focus, the awareness should be created just not amongst the medical community, but everybody in the society should be responsible for the green earth or green dialysis initiatives. Thank you so much for a wonderful and an amazing presentation. So Dina, are we good to go with the questions if they are there?
Yes, maybe we can start with the questions that we had previously.
Yeah, right.
So will you start? Okay. And thank you so much, Professor Van Holder, for this very, very, very wonderful lecture. And I think that this should be the future. And there are many initiatives, and those initiatives has to reach every each and single society, and local societies and regional societies. And by time, I think that this should be not just guidelines, but everyone has to be following those guidelines and following those environmental procedures and environmental measures, because it's a huge burden that we will pay the price for in the future. So we have, I think we have attendees from the Afghan, we have from other societies. So maybe this initiative should reach each and every local and regional society worldwide.
Yeah, Dina,
Yeah,
I think,
yeah.
yes.
Okay, sorry. I fully agree with that, but I think it's also important that there is an economic side of all this. That if dialysis becomes more compact and more environment friendly, it also becomes cheaper and more affordable for some countries where otherwise dialysis is, for the time being, too expensive.
Yes.
And you have mentioned that the first step is the prevention. So, and this brings us to the that we have just recently launched the World Kidney Day for year 2025. So I would ask everyone to log on to the page for the World Kidney Day and start acting and start screening and increasing the awareness among the population for the prevention and for the protection of chronic kidney disease, because it seems that this is the first and the most effective method to help protect our environment.
Yeah.
So
Yes,
maybe
so
we
I
start with
saw
the
that the topic of the WKD now is indeed for early detection, and I think early detection is important and not well exerted in most of the countries. But that's our responsibility to make people aware of that and to try to make this move also among other specialists, home practitioners, etc.
Indeed, yes. Yes, totally agree.
So, Dina, can we go for a couple of questions which have been posted earlier? Like,
Yes.
one question to Dr. Anjoin, like, what is the impact of the pesticides? It's a well-known, in fact, but I think probably we can hear it from you as well, that what is the impact of the pesticides in CKD? Pesticides are being used everywhere. In fact, in LMIC, the usage of pesticides is pretty high. Though the recommendations are there from the government policymakers with respect to the usage of the pesticides, when they're using it, the farmers are using it, the precautions not being taken. So we know that the pesticide exposure is high and the patients and the population is landing in CKD. So can you just enlighten on this aspect of pesticides and CKD? This was one of the questions. Over to Dr. Antoine.
Could you ask the question slowly and in a few words?
Pesticides related to chronic kidney disease?
Is what related?
Pesticides.
Yeah. Pesticides.
Exercise. Yeah, absolutely. So there is no debate. Yes, yeah. For many reasons, also because lack of exercise gives obesity, gives hypertension. So yeah.
So, Professor Antoine?
Yeah. You have to unmute yourself. Dr. Antoine, you have to unmute yourself.
We're not going to go through the, I had a few slides on the pesticide, but we're not going to go into it's not only one thing. It's, as you see, the CKD of unknown origin. In fact, it's a complexity of a structure where it combines different kind, not only one kind of pesticide, the dehydration issue related to the increase in temperature and the heat stroke, as well as the infection. So you cannot only take one thing and then pinpoint that this is the cause of so it's part of a context of a complex entity, what we call the CKD of unknown origin. So different type of pesticide are part of this. And the problem is that I don't think there is a strict regulation in the world, regarding the usage of pesticide, except maybe Europe and the US. But all over the world, people use pesticide, and it's a total anarchy. It's very important when we, try to always to ask questions about the origin of the food, the water used. All this are very important for our own health. So. Trying to eat 0 kilometer, I call it, food, which is brought locally or in an area where where this is the best way to eat, of course, to get the food, and of course to eat healthy food and avoid all this what we talked about. So there's no one specific thing for this pesticide.
Yeah, I know.
In
I mean,
India too.
certain, yeah.
Sorry, doctor, I just want to say in India too, we are getting into organic farming in a big way. And I hope that this will make a change. We're going back to basics and back to our agrarian days, to
It
natural
will, it
farming and
will.
organic farming.
Of course, there is an awakening. I think it's taking place. It's a global consciousness is taking place. The question is a matter of time before we reach this global consciousness. You know, we're talking about the transplantation at the least polluting in terms of the therapeutic approach for organ failure. In fact, if we work on prevention and transplantation by itself, if we work on organ donation, because today we don't transplant more than 10% of our need. So, you know, people are dying on the waiting list. So if we work to improve the rate of donation all over the world, which means enhance consciousness and awareness in the population about the importance of organ donation, that each person can save 8 people, then will eradicate completely organ failure, and we would not need because dialysis would still is a very costly procedure no matter what we do, and it would still be a polluting procedure no matter what we do. So I think the direction should be go to transplantation, but to go to transplantation, we need to create the awareness. Government should be more involved, be the major player in organizing the organ donation, and of course, the prevention of the disease. And it comes back to prevention of the disease, address the issue of pollution. Because as we have shown, environmental pollution today at all levels, visible and invisible, is causing the disease. So there is a work at the individual level, at the collective level, in terms of reducing the pollution, reducing the factors that impact on the pathogenesis of kidney disease, and of course, the treatment work toward more transplantation and organ donation. This is the way I see it as an approach. And of course, if we can make it, green dialysis, I think will be, but it's going to take time before doing all this, unfortunately.
Yeah, maybe addition of making stringent legislations and rules by the policymakers with respect to the use of the pesticides also may be one of the things which probably decreases the over-the-counter utilization of the pesticides amongst the farming community. So that also can be done by few countries. But again, what we feel, as Lata has said, that organic farming, it's going to increase potentially in numbers, and if the legislations can be in place, probably the impact of the pesticides can come down. Thank you, Dr. Antoine, for that. Question to Dr. Van Holle. This is $1 million question. So should we reuse a dialyzer? Should we not reuse a dialyzer? And in COVID-19, the amount of the biomedical waste that has been generated, and with the monkeypox that's coming up, of course, we are not so much threatened about the monkeypox, but then nevertheless, the amount of the biomedical waste that's generally generated with a single-use system is much more compared to the reuse policies. So do we vote for a reuse system, or do we go for a single-use dialyzer? That's $1 million question. I mean, probably you can just clarify on that. The other thing is, the next question is, what is a single step that you will suggest for us to have an effective green dialysis? 2 questions, Dr. Van Holle.
The first one, I think, yes, I'm definitely in favor of reuse, but it should be done safely. And I'm not entirely sure. So what we have for the time being is peracetic acid. And it's said that this is entirely innocent. I hope this is true. And then still the procedure needs to be done in a proper way, and no mistakes can be made. I have had reuse 30, 40 years at the beginning of my career in Ghent Hospital, but we saw a few accidents with that. So I'm a little bit concerned. So it needs to be entirely foolproof. And to do that, there must be people to organize this in a proper way. But it could be also an economic solution. But I think for economic reasons alone, I'm not very much in favor. I would go for single use, but for environmental, certainly it's an option. Now, what was the second one? That was
what's the single step that you suggest if units have
the single one? I think it's very difficult. I would at least suggest a few things. So the reduced flow, that's dialysate flow from 500 to 350. That doesn't make very much on dialysis adequacy. Transport of personnel. I mean, that people, not everyone comes by car, but that more environment friendly transport. Home dialysis, home hemo, PD. I think also, if we saw the data, I think there is reason enough to believe that PD does better than hemodialysis. Yeah, these are the most important ones, I think. And solar panels. Hospitals should use solar panels. They have surface area enough. If they can invest into this, it's also an economic advantage.
Yeah, right. Absolutely. But there is a tremendous increase in the number of the dialysis centers across the world. At least in India, there is a potential rise and hike, I can say, in dialysis centers, whether they are public sector hospitals or private or standalone centers. But then after the complete utilization of the machine for about 1400 hours, etc., something like that, how are we going to have that machine itself, which is made of so much of polymers, plastics, and all these things, is going to be a huge threat. The amount of the heat that the machine after utilization is going to generate is going to increase in future. So how do we overcome that part of machine?
I fully agree with you that's for sure. So that's why I think that our current therapeutic model must change, that we are too much working at the end of the spectrum and not enough paying attention to the beginning of the spectrum. So I reiterate what Antoine also said, the importance of transplantation, of prevention. And then also there must be, dialysis has not changed over 40, 50 years. In fact, there have been changes, but these are details. So the whole concept must be changed, and our whole concept of doing nephrology must be changed. That's the essence, I think.
So I know of a person who's trying to do research into the artificial implantable kidney. Do you think that that kind of a breakthrough will decrease the need for dialysis if you cannot have a transplantation?
I think that if your question is about research, I think that this is an important research area, which is not enough supported, I think. We have asked to the European Commission to put down more options for research projects on environmental impact of dialysis. The problem with policymakers is that they do not know very well what dialysis is and what the effect of dialysis is. So you have to explain kidney disease each time from scratch to all these policymakers. And it costs a lot of time to convince them how important it is. So that's something that doesn't happen from today to tomorrow.
So Professor Shubho Roy is trying in the University of San Francisco, and he says that he's just not able to get enough of funding for this artificial implantable kidney. So I think we could all try to think about how we can support research also. I think there's another question.
There's a question from Dr. Valerie. So she definitely has appreciated the great talks. Of course, there's no question about that. They're amazing and brilliant. So one issue that is not enough realized is impact of climate on the pregnant women, leading to preeclampsia, low birth weights, and preterm births, and probably appear to be all related. So apparently, this is one of the last questions posed by late, great Barry Brenner. So if we can take this question, probably, I think, Dr. Antoine. Climate impact on pregnant women.
I think it's, I have my personal theory, but there are several evidence that I think today, certainly the environmental pollution is responsible, the chemical part. But if you look at autism, for instance, I spoke about the electromagnetic, radiation. There is a lot of research in this regard regarding the impact on fetal growth, on miscarriages, on autism, on ADHD, on obesity, on diabetes. The data is full. If you look at the autism, for instance, in 1975, out of 10,000 autistic births, there were one autistic case. In 1995, you see the curve increasing worldwide, in the US and worldwide, about, on autism. What happened in 1995, there were the introduction of the mobile telephony. If you look at the usage of mobile telephony, the curve and the curve of autism increase, they're exactly the same. They're parallel. Today, we are at 42, out of 42 births, we have one autistic case. Now, you tell me how you explain this. I spoke about microwaving. The phone that we use has the same, if you look into it, potential intensity in terms of radiation as a microwave. Microwave, we heat water with microwave. The child, the baby, the fetus, when he is in his mother womb, his water, his composition is, I believe, 80 to 90% water. He's bathing into water. So the mother have the phone all the time, carrying the phone with her. So the child is exposed to this electromagnetic radiation. And the difference between the child and the adult, they have no protection for the brain. They have no skull. So the baby is, since the first cell, it is exposed to electromagnetic radiation. Then the baby is born. When the baby is born, we put the monitor on his head. I showed the list of electromagnetic. The monitor has the same power as the microwave. At 2 years today, more than 90% of the children at 2 years, they're exposed to the screen. So I think, and you see the data, please go in. There is thousands of papers. To me, I didn't know it till I went into the COVID and 5G, and I started to read. So I think electromagnetic radiation today, this is something we're never exposed to before. You see, the planet Earth has what we call the Schumann frequency. It is 7.8 hertz. Our body or brain can shut down up to 80 hertz. More than that, you don't feel. But the electromagnetic radiation has what we call thermal and non-thermal radiation. So the thermal radiation, we feel it. The non-thermal, our cell biology feel it, but not our skin, our sensory system. So when we are exposed to such radiation, for a long period of time, if you look at the 5G, for instance, few people know about the 5G. The 5G is 1 million times more powerful than the 4G, because in the gigahertz, this is something never humanity was exposed to. And there's no study on the 5G to show, what is the impact. We still have 30-year-old recommendation that, about but these recommendations of safety were done based on military, US military with big skull and big protection, not for children. So we don't know. And I don't think governments is going to do anything to protect us or to protect the population, because it is a business. Governments are run by businesses. So they have incentive. They will facilitate the spread of the 5G. They will do anything. And if you look at the WHO, there is today concern about the radiation, but nothing is done. So I think what we are concerned, not only the chemical, what we're seeing, there is an addition of the electromagnetic. And the problem, when you add electromagnetic to the chemical, they amplify and potentiate the toxic effect. This is science, not me. I'm saying this. That's why I propose the hypothesis that maybe the virus is produced, our own body had produced the virus under the exposure to multitude of simultaneous stressors that came at the same time, aggravated by the introduction of the 5G in November, 1 month before the spread of the, and our body produced the same way the animal produce antigens, our body also produced the exosomes. So this exchange between mammals, can cause this. The issue is when asked why the animals don't develop the disease, because we were told that from the bat to the pangolin, and we don't know how it get to human. The issue is about evolutionary process. The bat, for instance, is the only flying mammal. His heart beat at 1,000 beats per minute while flying, and it can reach 40 degrees Fahrenheit, 40 cellular degree, which means these are two conditions incompatible with life for any other mammal. Why? Because the bat in the evolutionary process is much older and has a stronger immune system. So he can carry the virus, transmit it, but he won't develop the disease. We humans, we are not exposed. We don't have the adult in the repertoire. That's why there were no danger for children, because the corona came as part of the new repertoire that their body is exposed to. The problem was with obese children, with morbidity, as I have shown you, that will die not from COVID, from any infection that will come to. So I think the COVID came really, and if you are interested, you can read, this is a very interesting review I did. I have never seen any review like this on the COVID from the outbreak all the way to the vaccine mandate. So I think the COVID really probably the same way any other viruses. You see, if you look at the flu, the Spanish flu, look into the history of it's not the Spanish flu, it's the American flu. In fact, it was the American soldiers after the World War I in 1918 that went all over the world and installed radars. And radars has exactly the same power, 30 giga to 60 giga as a 5G. And we were going out of a very global war, malnutrition, stress, all the things. And then came the radar that emit this electromagnetic radiation the same way as the 5G. So it was, in fact, not the Spanish, it was the flu, the American soldiers who spread the Spanish. And this is the first time we heard about when we talk about the pandemics, the virus. Before it was the bacterial pandemics, there were no viral pandemics. This was 100 years ago. And we celebrated the transistor, it was a few in 2018 or 2018, where the transistor was, spread all over the world and the radars. So I think we need to look into this. This is, nobody is speaking about, this is a source of trillions of dollars of businesses for all parties involved.
Yeah.
Thank you. I think it's well said. I think it's time that we need something about electromagnetic waves and kidney, or 5G and kidneys. I mean, the review that is done, I think everybody needs to know. It's the need of the hour. We should have certain regulations in place that will enlighten the public. I mean, that these are harmful. These are going to be harmful for the future that's coming. So thank you so much, Dr. Antoine.
We will never be able to stop technology, and we'll never be able to change the future. But we have to deal with it, and we have to be aware of the hazards and how we can deal with it
to protect ourselves. Exactly.
Yes.
Exactly.
Awareness and education are the key, I think, for the people, because technology, as you said, it's not going to stop. So thank you. Anyway, it's a very wonderful lecture. I think an amazing talks by both the speakers, lots of information. I'm sure there'll be a lot of questions as well. So Dina, over to you.
Okay. Thank you, Manju, and thank you for this very, very interesting session. And definitely we will have more questions, and we will pass it to our speakers, and we can have a continuation over Twitter or over LinkedIn later on. So maybe we can just give one word for Professor Raymond van Holder before we close, and Professor Antoine, if they have anything else to say. So, Professor Raymond.
I must say I have nothing to add. I think it was very interesting. We heard very interesting things. It's a complex issue. We have all a responsibility to try to sort it out.
Dr. Antoine, your closing remarks in this session?
Well, my closing remark, I agree with Dr. Van Holder, I think, but the problem issue today, humanity is in a subconscious state. And we need to create our role at the individual level and as a collective level for those who are willing to give their time, share their efforts and to contribute to this collective consciousness that I think hopeful one day it will take place and things will change completely in a much better way. And thank you for this really inviting me. It was an honor for me. And I hope we can participate in different sessions, webinars in the future.
Definitely.
Thank you. Thank you so much. Thank you, IFKF. Thank you, Dr. Dina, and thank you, the amazing speakers.
May I ask, is this recorded? Has this been recorded?
Yes, this is being recorded.
Yes.
Can we have the link for the
share?
Share? Okay.
Definitely. We will share the record with you.
So on behalf of IFKF-WKA, I'd like to thank Dina for curating this whole webinar. Thank you so much. And Dr. Manjusha for, being actively involved in IFKF and WKA activities. And Professor Antoine and Professor Raymond. I think it was absolutely enlightening. There's so much that we've learned today, and I'm sure it's really beneficial to all the people who attended, and especially all our IFKF-WKA members. And yes, maybe we will look at joining the European Kidney Health Alliance as well. I think team effort is something that's going to work at the end of the day. So we also request all of you to join hands with IFKF-WKA. We're a very small organization, but we are making and we need to make more of an impact on kidney health. So thank you, and thank you to Nirmala, Kausalya, and all of our team who also, and Kripa, who put all this together for us today, and all the efforts made by the technical team. So thank you so much. And it will be on our website soon.
Thank you.
We look forward to your joining us again.